Hello, this is Mark Sullivan. I am going to be giving a lecture on the right to pain relief, why the expansion from palliative care to chronic pain care was a mistake. This is based on a book that I have been writing with Jane Ballantyne, and it has been submitted as an article that's currently under review. So we'll take about a half hour for this talk, and then we'll have a discussion next Monday, I believe. So here's the outline of the talk. We're going to first introduce the idea of a right to pain relief. We're going to look at U.S. Supreme Court decisions about the right to assisted suicide, the right not to die in pain, and the right not to live in pain. We're going to talk about opioids as the answer to overwhelming pain, talk about the differences between palliative care and chronic pain care, and finally, we're going to talk about how a causal theory of mechanical impersonal pain as imposed from outside the person entails a moral theory of pain as undeserved or innocent suffering that will be the basis for the claim to a right to pain relief. So we'll begin by looking at what I think is one of the most succinct statements of the right to pain relief through pain medication. This comes from an article in the New England Journal of Medicine in 1989 by Sidney Wanzer and co-authors. He stated, "The proper dose of pain medication is the dose that is sufficient to relieve pain and suffering. To allow a patient to experience unbearable pain or suffering is unethical medical practice." I like this quote because it's very clear that it is about pain relief, that it is about pain relief through prescribed medication, and that there is a duty to provide that relief because the alternative is unethical medical practice. So to back up a bit and consider what was really accomplished by the 20th century palliative care movement. It arose out of Cicely Saunders in the UK. This movement simultaneously legitimated pain relief as an independent goal of medical care. So medical care had been focused in the 19th and 20th centuries on preventing premature death and at curing or controlling disease, but not so much on pain relief. It also legitimated opioids as a safe and effective means to achieve this relief. So those were two important innovations in the palliative care movement. Where the roots of the right to pain relief in palliative care come from a number of different sources, and we'll just hint at these. The notion of universal human rights was popular following World War II. And in 1948, the United Nations issued a Uniform Declaration of Human Rights. It doesn't have a lot to say about medical care, but it does point towards a right to medical care adequate for health and well-being. Later, but also under the auspices of the UN and the World Health Organization, there was a movement to improve pain relief in dying patients around the world. And the WHO and UN published a report called Cancer Pain Relief in 1986. Kathleen Foley was among the authors of this, and it specifically advocated improved pain assessment and aggressive pain treatment titrated to pain assessments. Soon thereafter, we got the 1989 quote that I just read to you about the right to pain relief in dying patients through palliative care. So soon thereafter, this notion of a right to pain relief for chronic pain was picked up. Notably, in 1990, Ronald Melzack, one of the two authors of the gate control theory of pain, a pain psychologist from McGill University, published an article titled "The Tragedy of Needless Pain" in Scientific American. And there he asked whether the duties to relieve pain that we had come to accept in cancer were not also applicable to chronic pain. What should be done for people who suffer from debilitating chronic pain but do not have a fatal illness? He argued that the same rights applied. Michael Cousins, soon thereafter, in 1999, he was a famous anesthesiologist in the pain world in Australia, argued that the relief of severe, unrelenting pain should come at the top of a list of basic human rights. By 2004, this had been extended. Cousin, Brennan, and Carr argued that failure to treat pain appropriately is substandard medicine. It's unethical. So we're at 2004 with this most recent Cousins article. By 2010, this same group had convinced IASP, the International Association for the Study of Pain, to issue their Declaration of Montreal, declaring a right to pain management. So this right to pain management was explicitly intended to be broader than a right to pain relief through opioids. However, it's quite difficult to implement multidisciplinary care outside of high-income countries and integrated care systems like the VA. Therefore, this right is often interpreted by patients and implemented by health systems as a right to pain relief through pain medications, which is the form that it was stated by Wanzer. All right, switching gears a bit. During the similar time frame, right at the end, the last few years of the 20th century, the US Supreme Court was asked to make a ruling on whether terminally ill patients had a right to assisted suicide. There were two cases decided by the court in 1997, Washington v. Glucksberg and Vacco v. Quill. In each of these cases, the court denied that there was a constitutional right to assisted suicide for terminally ill patients. The palliative care community successfully argued that assisted suicide was not necessary because pain and suffering can be almost always relieved by skillful palliative care. But in denying the right to assisted suicide, the court came very close to declaring a right to pain relief for dying patients. The court found that there was no ethical justification for allowing dying people to suffer intolerable pain unless they chose to do so. Justice Sandra Day O'Connor articulated this right not to suffer unbearably at the end of life. Quote, "The laws before us do not force a dying patient to undergo that kind of pain." So around the same time, there were concurrent guidelines and legislation regarding chronic pain. So the Supreme Court decision was about palliative care, but there were other things happening in the domain of chronic pain around the same time. In 1997, the American Pain Society and the American Academy of Pain Medicine released guidelines on opioids and the treatment of chronic pain that it specifically endorsed opioids as a component of chronic pain treatment. In 1998, the Federation of State Medical Boards model guidelines on the use of controlled substances also endorsed opioids as a central component in treating chronic pain. In the very next year, many states passed what were called intractable pain acts. These are acts that removed limitations on opioid dose or duration of treatment that had been present for decades in state law. I quote the example here from Washington State, where the Intractable Pain Act stated, no disciplinary action will be taken against a practitioner based solely on the quantity or frequency of opioids prescribed. So this turn to opioids as an answer to overwhelming pain has its own history. It's important to remember that opioids were not first discovered in the mid-90s when the extended release opioids like OxyContin first were released. In fact, the US had its first opioid epidemic arguably in the late 19th and early 20th centuries. There were a fair number of Civil War veterans that had become dependent, if not addicted to opioids, and there were hundreds of thousands of women dependent on opioids who had been treated for various female complaints, postpartum syndromes, fibromyalgia, things like that. As a result, in 1914, the US passed its first law regulating narcotics, the Harrison Narcotics Tax Act. And although the primary focus of this act was taxing these narcotics, it began the distinction between legitimate and illegitimate opioid uses. And prescription of opioids for the treatment of pain by licensed physicians was called out as legitimate opioid use, whereas treatment or in any way kind of palliating addiction was considered illegitimate opioid uses. It's important to remember that there were many patent medicines marketed for all sorts of complaints that contained opioids, cocaine, many of these things at that time. In 1970, under the auspices of Richard Nixon, the Controlled Substances Act was passed. And this created the now familiar schedule system by which substances are grouped by medical use and abuse potential, where we have Schedule 2 opioids, Schedule 3, etc. This further distinguished medical uses and what were considered to be abuses or addiction. However, this created a pretty strong and punitive regulatory apparatus around these substances that some felt had become an opiophobia. And the palliative care community in the 1990s helped overcome this opiophobia by demonstrating that opioids were a safe and effective treatment for terminal pain, that there was little addiction and that the pain could actually be relieved through this technique. So one of the principles utilized and disseminated by the palliative care community about the proper use of opioids is called the titrate to effect principle. This is based on the idea that it is not possible to predetermine the proper dose of opioids in palliative care. There is no standard dose like a standard aspirin dose or a standard antihypertensive dose. One must determine what dose of opioids significantly reduces pain. You have to titrate the dose of opioids to the effect of pain reduction to discover what the right dose of opioids is. This worked pretty well in palliative care. However, the implementation of titrate to effect in chronic pain care has been disastrous. we have found that titrate to effect in chronic pain care may reduce pain scores, but also reduce daily function to little more than couch sitting. You drive down both pain and the capacity to function over time with aggressive opioid dosing. It's also true that titrate to effect tends to select the highest risk candidates with psychiatric comorbidity for the highest opioid doses, because it is these risky candidates who tend to rate their pain the highest. And so they tend to get highest opioid doses and then have high rates of adverse events like addiction and overdose. Probably most importantly, when the right to pain relief is combined with titrate to effect, that creates the implication that a high pain score cannot be ignored. It, in effect, establishes patient expectations about pain relief and clinician duties about pain relief that we argue played a central role in vastly expanding the use of opioids and in creating what we now know to be the opioid epidemic. So, why did this go awry? Why did right to pain relief and palliative care become a disaster when it was translated into chronic pain care? We can examine a few important contrasts about the clinical situation. First of all, palliative care occurs in patients who are dying classically, and this is a time frame generally of weeks to months. Whereas chronic pain care has an indefinite time frame and may stretch for years to decades. It's common for people on opioids for chronic pain to have been on opioids for decades. So this is a very different time frame within which opioid dependence and tolerance can develop. Second of all, the setting, palliative care generally occurs in inpatient settings. If it is occurring like in a home setting, a hospice kind of setting, it's a very confined care setting. Whereas chronic pain care occurs while patients are living at home, trying to work, meet their household duties. This is a quite different setting. The context is different. So in palliative care, one is treating pain while the patient is dying. And in fact, disrupting the dying process is one of the main downsides of aggressive pain control. In chronic pain care, you're treating pain while the patient is trying to do everything that is common in a normal human life. Going to work, having relationships, taking care of a household, supporting a family. In palliative care, opioid dosing in titrate to effect is titrated to pain level. And that is appropriate in a context dominated by medical concerns. In chronic pain care, precisely because of this problem where you may lower pain levels but also lower function, it's not clear what the right target is that opioids should be titrated to in chronic pain care. They were often titrated to pain levels with deleterious effects on function. Others have argued that we should titrate to function or to quality of life or to capacity to work, but there's been no real consensus about what the right target for titrate to effect is in the chronic pain setting. And finally, the iatrogenic harms of aggressive pain control through opioids and palliative care are really limited to hasten death. It is well acknowledged that if you aggressively move to control pain, you may compromise respirations, you may in fact make the patient apneic and die. That has been addressed and justified for many years through the principle of double effect, where it is argued that you can have a bad effect as long as it was not your intended effect. So you're intending to relieve suffering, and if the patient happens to die, that even the Catholic Church said that was all right. However, the iatrogenic harms of using opioids in chronic pain care or titrate to effect was much broader, where you have clinical harms to the patients themselves in the form of overdose and addiction, social harms to non-patients due to diverted drugs, cultural harms concerning the status of pain and the role of self-management in society broadly. All right. So it's also interesting to look at the contrasting roles of pain and disease in palliative care and chronic pain care. So palliative care is dominated by pain from disease. By definition, the palliative care situation has a terminal disease as a clear cause for pain. So the reality of the pain, the legitimacy of pain control is all quite clear. There's not really any stigma involved. And in the current atmosphere, little debate about whether we should do what we can to relieve this pain. Chronic pain care, the role of disease is much more variable and less clear. Chronic pain is famously not linearly related to amount of tissue damage. In some kinds of chronic pain problems, common nociplastic pain syndromes, there may not be any peripheral damage to be found. And the role of opioid therapy in many of these pain syndromes like fibromyalgia is unclear. In fact, no treatment guidelines recommend opioid therapy for fibromyalgia. Another interesting contrast between palliative care and chronic pain care concern the different roles of pain and suffering. So palliative care, one of the real contributions of palliative care is it reintroduced suffering as a target of care within hospitals and other healthcare institutions in the 20th and 21st century. It's been quite convincingly argued that suffering was neglected in 19th and 20th century medicine as disease became the focus of modern medicine. This is one of the problems that Benica, for example, argued about. But having initially fought hard for opioid liberalization, the palliative care movement is no longer really focused on that. It's not the focus of palliative care innovation anymore. Now, palliative care is much more focused on multidisciplinary team care, effective communication, defining and targeting patients' quality of life through goals of care discussions. Chronic pain care, on the other hand, tends to see suffering as caused by pain. Suffering, whether it be anxiety, depression, or other negative affective states, are seen as a reasonable reaction to pain. This is often the way that it's described by patients and clinicians alike. And this, we believe, derives from understanding pain as the mechanical product of tissue damage. It's something that happens outside yourself and is imposed upon you. It's not deserved. It's not something that you did, and therefore you are someone who is innocently suffering from this pain. So what about suffering? Again, we're going to zoom out a bit to look at this even more broadly. So Martin Luther, those of you who remember, he initiated the Protestant Reformation in Europe in the 1500s. He distinguished between what he called essential suffering and inessential suffering. Essential or inescapable suffering is the suffering that's inherent in human life and that we must learn to accept. The fact that we die, the fact that we suffer losses throughout our lives. And this is contrasted to inessential or escapable suffering that we can address and reduce. So classically, religion has helped humans with essential suffering by finding meaning in it, explaining it, putting it into context, providing solace. Whereas medicine has played a central role in reducing inessential suffering. In fact, it's been successful at pushing back the boundary between essential and inessential suffering. Pain during surgery, for example, in the past was thought to be inescapable suffering. There was efforts to do the amputation as quickly as possible because the pain was so awful. But now we don't have that. We have anesthesia. And medicine, in its role, has been less interested in pain meanings than in pain mechanisms. And that's because instead of asking why we are in pain, like religion would do, medicine asks how we are in pain because it seeks to explain and control pain, not so much to find meaning in it. Hence, we have constructed modern medical pain as a form of innocent suffering. Even though we've modified this, modern medicine still understands pain as the mechanical product of tissue damage imposed on the person from outside the person. This is the basic causal theory of pain that we operate with. And that entails seeing the person as the victim of innocent or undeserved suffering. So the causal theory implies a moral theory. And this understanding of pain as innocent suffering is the basis for the claim to a right to pain relief. You know, the right to pain relief rings okay in our ears, whereas similar things like a right to suffering relief or a right to anxiety relief just does not ring as convincingly in our ears, because we see that the person cannot just claim in a medical setting to be relieved of all suffering or all anxiety. They're thought to need to participate in that process of relief. But for pain, we're more willing to consider that as a purely medical problem. So, human pain and suffering breach the boundary between the personal and the impersonal in an interesting way. I don't know if some of you remember Eric Cassell, bioethicist, internist, very famously argued that suffering arises from threats to the integrity of the person, not just to the body, but the person, including all the relationships, identity, etc. In chronic pain care, we understand this personal suffering as a reaction to impersonal pain. Remember that impersonal pain is transmitted by a nociceptive system and a pain system that occurs outside the person. And to reduce suffering, we reduce pain through opioid therapy. A problem with this is that, in fact, opioids are not highly specific painkillers. They're called that in the popular press, but in fact, we've known since the endogenous opioid system was discovered in 1973 that opioids have diverse and essential functions in the human brain, subserving social, emotional, endocrine, reproductive function, all sorts of things. Furthermore, it's not true that the relationship between human pain and suffering is a simple linear one from pain to suffering, that there is a bidirectional relationship where other forms of suffering, whether they be grief, depression, psychological trauma, demonstrate that the relationship between pain and suffering is bidirectional. So in conclusion, how do we understand the difference between opioids in palliative care and opioids in chronic pain care? Palliative care is a temporally and spatially bounded situation dominated by medical concerns. The patient is dying, the patient has a terminal disease, the disease is going to cause death, but it's also causing pain. That is the mandate for pain control, titrate to effect, and opioid use in that situation. Chronic pain care, on the other hand, occurs in a temporally and spatially unbounded situation that includes the full breadth of human life, relationships, working, emotions, cognition, that are much more complicated than what needs to be considered in the palliative care situation. This means that the risks of opioid therapy differ. In the palliative care situation, we risk disrupting the process of dying, in fact, hastening the patient's death, versus in the chronic pain situation, we risk disrupting the process of living, putting the patient with a lower pain score on the couch all day. So I hope you have found this talk to be interesting. And as I mentioned, we will be publishing a book from Oxford University Press later this year that will cover this topic and other related topics in some detail. Thank you for your attention, and